talk about the IOLs, yes, today it is getting very confusing also, and at the same time, surgeons have got a huge opportunity in terms of various types of IOLs available. So, when we talk about the IOLs, the monofocal plus the EDOF lenses and all, I would just like to ask the audience first that who all among you are actually implanting these sorts of premium IOLs? Is it everybody or there are still the limited number? Can you raise your hands? So who are actually wanting to implant more of EDOFs? Can you raise your hands? And when we talk about EDOF, any takes, like what all are your lenses of choice? Anybody please? Okay.
Refractive segmental.
Pardon, sir?
Refractive segmental EDOF.
Refractive segmental, like
a lentis and femtis.
Okay. So when we talk about these lenses, there is a huge gap, like need to understand that there are lenses called as monofocal plus and lenses called as EDOF lenses. So monofocal plus, I would say, is just a step ahead of monofocal lenses, and they give a slightly better intermediate vision as compared to the normal EDOF lenses. And the EDOF lenses are one which give a better depth of perception, and you can actually view up to about an N8 or N10. Am I right, Dr. Bhalla?
Yeah, very true, sir.
So all these lenses actually play with a little optics transformation. Some have got those spherical abrasions, some have got a conventional refractive change in their posterior surface, some have got that the central area is a little changed in the refractive zone. So most of these lenses do not come absolutely free of any kind of issues and or any problems. The patients do have slight problems with most of the EDOF lenses in terms of their distance corrected visual acuity. So any of you guys would like to just share your experience, that what you have experienced with the EDOF or the monofocal plus lenses? Anybody?
Don't have much problem with the distant vision, but the near vision is quite variable. I am most of the time implanting Renner EMV. I don't have much experience with various EDOF lenses, but 6.6 even with the EDOF toric is also pretty good. Near vision may vary a lot.
So what do you see in your near vision, like your experience?
Starting from N6 to N10, rarely N12. N6 is also achievable in many.
So why this actually difference is there is because the classical Renner the Renner EMV lenses plays on the idea of the spherical asphericity. Like it has a change of asphericity in the central zone, and it actually plugs in with your cornea. Like how the cornea is. If the cornea actually theoretically is bang on according to the lens, the lens may behave in a better way, and at the same time, if the asphericity of the cornea does not plug in with your lens, sometimes you may not get as good the results. And similarly, when we talk about these lenses in the post-refractive surgery eyes, like we saw in the Shah Rukh Khan typical case, that the patient was absolutely unhappy with the vision he had, because that eye was already actually operated upon for his refractive correction once, and the asphericity did not match with the lens which was implanted, and the results were not as per the expectation. So we need to be very careful in selecting our IOL, that which sort of lens would fit in these patients. Sir just pointed about PureC lens. So PureC works on the platform of the change in the refractive curvature on the posterior surface. So that lens is comparatively very forgiving. I have actually experienced with most of the lenses. Almost I have implanted about close to 100 PureC. I have implanted about many of about 100 or so about an EMV lenses, Evolux, the ISO pair, most of these lenses. But I would say that the iHands, Evolux, Renner EMV or the ISO pair would actually fall in the category of the monofocal plus, with a slight variation in these. Like some may give a better near correction and some may give you a less, depending upon the cornea, depending upon the patient. And the results are definitely not very consistent with most of the lenses. You may see a gross variation. And the other thing with these lenses, as you play with the asphericity or you play with the optics, the tolerance of these lenses to a residual refractive error also increases. So you need to be very much close to emetropia, whether in terms of your astigmatism, whether in terms of your residual refractive error. Especially I would point out towards astigmatism, because the phenomenon which you would see in a regular monofocal lens with a 0.5 or a 0.75 residual error must be much exaggerated with these lenses, because the optics in the central zone of these lenses is much modified and the patient already has some dysphotopsias which get exaggerated with the residual refractive error you have. So if you want to achieve a happy patient, you need to be very precise in your biometry, you need to be very precise in the selection of the lens which you are doing. But most of the lenses like the Pure C or the Eye-Hands, which actually do not play with the asphericity, are comparatively a bit more forgiving as compared to the ones in which the optics is modified in the center.
So do you recommend, Piyush, if you have to implant these EDOF lenses or monofocal plus lenses, we should also measure the higher order abrasion of these patients?
Yes, of course, but none of the instruments actually available on date give you a correct estimation of the corneal abrasions. It would give you of the complete eye with the lens inside and everything. But to separate out the corneal this asphericity is still not 100% achievable. And even with an instrument like eye trace, if you actually see, eye trace may actually show that the patient, the cornea has this kind of an asphericity and the lens may not suit you, but surprisingly the patient may be happy, or even vice versa. Yeah. So you cannot actually trust upon the instrument or the measurement very much accurately on date.
Thank you, thank you. I think this is very nice input which really fits into this IC of achieving a target.